Good day, everyone. I am Krisha Matiswarag, and now I am going to identify the ethology or ethologies, evaluation, and also the treatment of dysmenorrhea. Dysmenorrhea. Dysmenorrhea is the medical term for painful menstrual period which are caused by uterine contractions, and primary dysmenorrhea refers to recurrent pain, while secondary dysmenorrhea results from reproductive system disorder. Both can be treated. Ethologies. Ethology many theorists have explained the ethology of dysmenorrhea since the 1960s. This includes psychological, biochemical, and anatomical ethologies. The anatomical theory included abnormal uterine position and abnormalities in the shape or the length of the cervix. In their study, proposed a positive correlation between the cervical length and the volume and intensity of dysmenorrhea. The biochemical theory has proven to be stronger than others according to several homogeneous studies. Associated risk factors are age, smoking, attempts to lose weight, higher body mass index, depression or anxiety, earlier age at menarche, nulliparity, longer and heavier menstrual flow, family history of dysmenorrhea, and also description of social. There are two types of dysmenorrhea, primary and secondary. Primary dysmenorrhea is the name for common menstrual cramps that come back over and over again and aren't due to other disease. Pain usually begins 1 or 2 days before you get your period or when bleeding actually starts. You may feel pain ranging from mild to severe in the lower abdomen, back, or thighs. Pain can typically last 12 to 72 hours, and might have other symptoms such as nausea and vomiting, fatigue, and even diarrhea. Common menstrual cramps may become less painful as you get older and may stop entirely if you have a baby. Prostaglandin or PGF is the main contributor to the cause of dysmenorrhea. The time of the endometrial shedding during the beginning of menstruation is when the endometrial cells release PGF. Prostaglandin or PG causes uterine contractions and the intensity of the cramp is proportionate to the amount of PGF released after the sloughing process that started due to a dropping hormonal surge. This pain caused by natural chemicals called prostaglandins are made in the lining of the uterus. Prostaglandins cause the muscle and blood vessel of the uterus to contract. Factors that correlate positively with dysmenorrhea are smoking, early menarche, nulliparity, and family history. Secondary dysmenorrhea. Secondary dysmenorrhhea. Presentation is a clinical situation where menstrual pain can be due to an underlying disease disorder or structural abnormality either within or outside the uterus. If you have painful periods because of a disorder or an infection in your female reproductive organ, it is called secondary dysmenorrhea. Pain from secondary dysmenorrhea usually begins earlier in the menstrual cycle and lasts longer than common menstrual cramps. You usually don't have nausea, vomiting, fatigue, or diarrhea. Menstrual pain from secondary dysmenorrhea is a result of problems with the reproductive organs. Conditions that can cause cramping include: first, endometriosis, a condition in which the tissue lining the uterus or the endometrium is found outside of the uterus. Because these pieces of tissue bleed during your period, it can cause swelling, scarring, and pain. Second, endometriosis, a condition where the lining of the uterus grows into the muscle of the uterus. This condition can cause the uterus to get much bigger than it should be, along with abnormal bleeding and pain. Third, pelvic inflammatory disease, or PID, an infection caused by bacteria that starts in the uterus can spread to other reproductive organs. PID can cause pain in the stomach or pain during sex. Cervical stenosis, narrowing of the cervix or the opening to the cervix to opening to the uterus. Fibroids, benign tumors, growths on the inside, outside, or in the walls of the uterus. If you have painful periods, you may have feeling of pressure in the abdomen, pain in the hips, lower back, and inner thighs. Evaluation. Primary dysmenorrhea is diagnosed depending upon the history and physical examination. A pelvic examination is important for evaluating dysmenorrhea if the history of onset and duration of lower abdominal and pain suggests secondary dysmenorrhea, or if the dysmenorrhea is not responding to medical treatment. Second, the use of ultrasound in the evaluation of primary dysmenorrhea has a little significance. However, ultrasounds can be useful in differentiating secondary dysmenorrhea and causes that include endometriosis and adenomyosis. Secondary dysmenorrhea affects all women in any time after menarche. While it can happen as a new symptom for females in their 30s or 40s, it can be associated with different intensity of pain and other symptoms such as dyspareunia, menorrhagia, intermenstrual, postcoital bleeding. Third, the pregnancy test using urinary human chorionic gonadotropin or BHCG are useful in history suggestive of suspected pregnancy. Patients who are at risk of sexually transmitted infections or STIs or when pelvic inflammatory disease (PID) is suspected will need endocervical or vaginal swabs. Indicated by clinical examination and history to the rule out suspected malignancy, cervical and cytology samples may be required. And lastly, the treatment of dysmenorrhea. Pharmacological treatment, non-steroidal anti-inflammatory drugs or NSAIDs are considered to be the first line of treatment for dysmenorrhea. NSAID are very effective in the treatment of dysmenorrhea in comparison to placebo or other therapy. NSAID exert their benefit to the treatment of dysmenorrhea by inhibiting cyclogenase enzyme and thereby blocking the prostaglandin productions. Bifenamic acid may have slightly better efficacy than the propionate acid derivatives ibuprofen and naproxen because phenamics have a dual action of blocking the production of PGs and inhibiting their actions. One study recommended ibuprofen and phenamics preferred in terms of safety and efficacy. NSAID are still more effective compared to paracetamol. Oral contraceptive pills or OCPs are reported effective in reducing the dysmenorrheic pain compared to the placebo among adolescents. May other studies argued against the effectiveness of OCPs as a treatment for dysmenorrhea due to small sample size and limited comparative data. OCPs have a mechanism by limiting endometrial lining growth. Progestin-only pills, or POP, are suitable more for patients with secondary dysmenorrhea related to endometriosis, where areas that recognized as a treatment for primary dysmenorrhea is not evident. POPs mainly works by causing atrophy of the endometrial lining and by inhibiting ovulation. Non-pharmacological treatment. Maintaining an active lifestyle and a balanced diet that is rich in vitamins and minerals are generally recommended for better health outcomes. In particular, such a diet, life, and lifestyle are useful to reduce the intensity of the dysmenorrhea. And this through that different types of exercise are generally recommended due to severe health benefits and low or no rate is also help reduce the intensity of dysmenorrhea. No clear evidence about certain exercise activity or specific duration, but moderate exercise is recommended, especially in obese women. And for the best relief, take ibuprofen as soon as bleeding or cramping starts. Ibuprofen belongs to a class of drugs called non-steroidal anti-inflammatory drugs or NSAIDs. They reduce the output of prostaglandins. If you can take NSAIDs, you can take another pain reliever like acetaminophen, place of heating or powder water bottle on your lower back or abdomen. Please, when needed, avoid full contained caffeine, avoid smoking and drinking alcohol, massage your lower back and abdomen. Women who exercise regularly often have less menstrual pain. Cramps make exercise a part of your weekly routine. If these tips don't relieve your pain, your health will prevent you. And that's all. Thank you.